Hello, it's me again, Dr. Neurosurgery Greenberg, and we are continuing with the pituitary evaluation. And here we have a thyroid issue, the thyroid screening. The thyroid screening is done in order to let us know if the pituitary is messing with the thyroid as well or not. Now, first of all, you need to know that we only test free or total T4 and TSH. So here what we need to remember is if both the things are low or both the things are high, then the cause is central, somewhere in the brain. But if something is high, the other thing is low, like T4 is high, T4 and TSH is low, or the opposite, then it means that the problem is in the thyroid. It's primary hypothyroidism or hyperthyroidism, and we look at it in detail. So after this generalized rule, we come to the table itself, and in this table, we can see first of all primary hypothyroidism means the problem lies within the thyroid gland itself. And in this case, the TF4 will be low, whether it's free, whether it's total. But the TSH, the stimulation from the pituitary, is high. And it can happen when chronic primary hypothyroidism produces secondary pituitary hyperplasia. That is the pituitary pseudotumor. It's not a tumor. The problem is that the pituitary thinks it is not loud enough that the thyroid can listen to it, so it becomes hyperplastic and releases more TSH. But again, T4 is still low. And this is indistinguishable. This hyperplasia is indistinguishable from an adenoma on CT or MRI. And if any patient comes with a pituitary mass, it could be hyperplasia. Okay, not every CT, MRI, pituitary mass is an adenoma. Then what is the pathophysiology behind it? Loss of negative feedback from thyroid hormones causes increased TRH release from the hypothalamus that produces secondary hyperplasia of the thyrotropic cells in the adenohypophysis through hyperplasia. And the patient may present due to pituitary enlargement with visual symptoms, elevated prolactin from Stalk effect, and enlarged cell ataxica on X-rays. So everything will point to a tumor-like feature. Visual symptoms will be there. Prolactin will be elevated due to compression of the pituitary stalk, and the cella will be enlarged on X-ray. So you will think, okay, it's an adenoma. Now, chronic stimulation from elevated TRH may rarely produce even thyrotroph adenomas. Okay, and labs will show T4 low or normal TSH elevated. How elevated? It will be more than 90 to 100 in patients. Earlier on, we learned that free T4 level was 0.5 to 1.5. Total T4 was 4 to 12, and TSH was 0.4 to 5.5. But here it's in hundreds. And prolonged and elevated TSH response is due to TRH stimulation. Okay, and you can test it as well, but usually we only do TRH testing after abnormal T4 and TSH levels come. Next comes secondary hypothyroidism, insufficient TSH stimulation of the thyroid. So pituitary over here, actually T4 and TSH both are low, and here there is central hypothyroidism. So pituitary hypothyroidism accounts for only 2 to 4% of all hypothyroid cases. So mostly the hypothyroidism is due to thyroid itself, but sometimes it can be from the central causes. Secondary hypothyroidism was found in 8 to 18% patients with non-functioning pituitary tumors, as pituitary compression reduces the TSH released. And here we have seen that the T4 will be low, the TSH will be low, and even the TRH stimulation response will be low. In primary hypothyroidism, the TSH response to TRH stimulation was elevated. Now coming to primary hyperthyroidism, in which the problem is with the thyroid gland itself, and T4 is raised, but TSH is low. TSH, the pituitary wants to control the T4, but it is out of control. So what is the etiology? There may be localized hyperactive thyroid nodules, circulating antibody that stimulates the thyroid, or diffuse thyroid hyperplasia itself, which is Graves' disease, also known as ophthalmic hyperthyroidism. And over here again, labs T4 will be elevated and TSH will be subnormal. Sometimes it is undetectable. Then secondary hyperthyroidism, which is central hyperthyroidism. Both arrows are going up, T4 and TSH. The etiology may be a TSH secreting adenoma, a pituitary resistance to thyroid hormones, which disrupts the negative feedback loop. And that's all for the thyroid. Now coming to prolactin levels. If the levels are 3 to 30 nanograms per ml, it is normal in a non-pregnant female. If it is 10 to 400, it may be because of pregnancy, and 2 to 20 is in postmenopausal female. Now, if the value is from 25 to 150, there is a moderate elevation, maybe due to prolactinoma, stalk effect, or other causes. And if more than 150, this is a significant elevation and a prolactinoma is most likely there. And sometimes even 200 nanogram is considered a cutoff. Okay. And ectopic sites of prolactin secretion have been reported, like in a teratoma. That is what you have to remember. So again, we come back to stalk effect. In the previous slide, we learned about it, but we are going to discuss it again. So a modest elevation of prolactin level due to loss of inhibitory effect of prolactin inhibitory factors from the hypothalamus is stalk effect. A rule of thumb is the percent chance of an elevated prolactin being due to a prolactinoma is equal to 1/2 of the prolactin. So that is all about this today. We are going to discuss something more about pituitary in the next slide. See you then, and thank you.